Dear colleagues, dear friends, first of all, I start with our therapeutic or treatment concept. Any tumor for which a curative procedure with preservation of function seems feasible is treated primarily by transoral laser microsurgery. If neck surgery is indicated, a selective neck dissection, and the neck dissection is routinely performed for N0, N1, and N2 cases, primarily as a delayed procedure. Adjuvant radiotherapy or chemoradiotherapy is mainly indicated for advanced neck disease. It can start as early as 2 weeks after surgery. This is a very important advantage, that the patient can be treated by radiotherapy when the wound is still open. We have blood circulation in the organ, and we have performed only selective neck dissection. So we have radiobiologically the best conditions for postoperative treatment. The main principle is less surgical radicality without loss of oncological radicality. Surgeons should have appropriate experience in endoscopic anatomy and microlaryngoscopy. The key for this kind of surgery is adequate exposure with the help of special laryngoscopes, instruments, and manipulation of the larynx from outside. Careful examination of the margins by the pathologist is basis for verification of a sound resection. Finally, one needs a patient's compliance in abandoning carcinogenic habits and cooperating in follow-up. And the preconditions for organ preservation is the appropriate patient selection. There should be a high probability of preservation of functionally important structures. Functional disorders like severe persisting aspiration after extended resections and extensive tumor spread to the neck represents a real limitation of this procedure. In laryngeal cancer, at least one arytenoid cartilage, and in hypopharyngeal cancer, at least half of the larynx should be preserved. And in hypopharyngeal cancer, about 2 centimeters of the circumference of the hypopharyngeal mucosa and half of the upper esophageal mucosa should be preserved for functional reasons to avoid persisting aspiration and stenosis. Das Licht ist aber nicht so gut. Das Licht ist sehr stark. Da kann man die endoskopischen Bilder nicht sehen. Jetzt kommen auch ein paar Videos. Das wäre schön, wenn Sie das ein bisschen dimmen können. Here you see a larynx in a 91-year-old patient full with tumor and with no more mobility of the arytenoids. And if you like to remove the tumor curatively, you can do it under surgical technical aspects. You can remove the larynx completely transorally, but the patient will not swallow anymore. So in this patient, if you remove both arytenoids as a first treatment, so you will have a non-acceptable aspiration. So we have in this patient reduced, debulked the lesion, and then the patient had radiotherapy and then survived 3 years. Now I show you the first case. Is a 81-year-old patient with dyspnea. He had a bilateral vocal cord subclottic cancer, anterior commissure, and spread out to the neck through the cricothyroid membrane area. So it was a T4 lesion, and you will see at the end of operation, you see here the trachea, parts of the thyroid cartilage and cricoid cartilage are removed to be sure that the tumor is completely removed, and you see the subcutis, though the resection goes to the cutis. And we have a big defect in this old patient, and he had no tracheotomy. And this is after 16 months. You see this scar, some scar formation anteriorly. And I show you the case not only because he's an old patient, but to demonstrate the unbelievable healing.
Wie geht es Ihnen?
Mir geht es gut. Keine Beschwerden.
Gibt es irgendwelche Probleme beim Essen oder Trinken?
Nein, nein,
Sie verschlucken sich nicht beim Essen oder Trinken?
nein.
He has no
Mit
aspiration.
Ihrer Stimme können Sie sich ausreichend verständlich machen?
Danke.
Wunderbar, dann hoffen wir, dass es dabei bleibt.
This patient had N0 neck, 81 years old, no radiotherapy, and is now over 3 years free of tumor. I will show you very briefly some results regarding the moderately advanced tumors here, T2B, vocal cord mobility impaired. This tumor entity is biologically, prognostically, and therapeutically very similar to the T3 vocal cord fixed lesion, and you see that most of the patient had laser only, but in T3, every second patient had a combined treatment, mainly with neck dissection, some of them combined with radiotherapy. And when we look at the complication, you see that we had one bleeding, one stenosis, 2 edema. These were patients who needed another microlaryngoscopy for treating the complications, and 3 patients had tracheotomy. About the functional results outcome, Petra will give later some comments. Well, these are the results, and you see that the T2B, the 5-year recurrence-free survival, are very similar to T3, and overall survival is very similar in both groups. So this is why we have recommended since many years to consider T2B vocal cord cancer as a T3A vocal cord cancer. Now we come to the supraglottis. This patient has a T3 tumor, pre-epiglottic space, paraglottic space bilaterally down to the vocal cords, as you will see at the end of surgery. Here you see the vocal cords, and you see the clip in the artery, laryngeal artery. Here's anterior, the completely removed the pre-epiglottic space, paraglottically removed and preserved both arytenoids. Here are the arytenoids. And this is 1 day after surgery. You see the wound with fibrin
Wie geht es
exudation.
Ihnen?
Danke, mir geht's sehr gut.
Sie können sich also ausschließlich über den Mund ernähren.
Ja,
Here you see the closure, good sphincter function, so the patient is able to eat and drink. And when we are talking about quality of life, these patients all have quality of life. You don't need a questionnaire. No tracheotomy, no feeding tube, good voices. This is for social life and for professional life, normal life for this patient. And this is, in my opinion, these are the most 3 important factors when we evaluate the quality of life. In supraglottic carcinoma, Dr. Knecht asked me to talk more about advanced disease and not about early. So we're looking at supraglottic cancer in stage 3 and stage 4. You see that most of them had a combined treatment with neck dissection, and in stage 4, 32 had every second patient had a combination with neck and radiotherapy. Here you see we have a higher rate of bleeding in vocal cord, T2B, T3, only 1 case, but here 13 cases, some edema which needed microlaryngoscopy, excisional edema treatment, 3 stenosis and 2 aspiration pneumonia. And the rate of tracheotomy in T3, T4 electively, and due to aspiration 2 and due to bleeding, 1 patient needed tracheotomy. Now to the oncological results. You see in T3 and T4, the 5-year local control rates, 79 Kaplan-Meier curve and estimates, and 69 salvage laryngectomy, 5% and 16%, overall survival and 5-year recurrence-free survival. These are results comparable with results after total laryngectomy. But of course, the problem is that we cannot compare the results. We can show only with the results of one or two institutions only a trend, and we cannot prove it. We need prospective studies. Now we come to the piriform sinus tumor, the last topic. You see a piriform sinus cancer with involvement of the vallecula, of the larynx, of the postcricoid region. There was a microcarcinoma on the postcricoid region, and lateral wall, anteriorly and medial wall infiltrated. End of surgery, here the epiglottis, and here the soft tissue of the arytenoid right was removed. The cartilage itself was preserved. You see the lateral wall of the thyroid cartilage, and this is 1 day after surgery. And you see that we are lucky that the vocal cord is still mobile, and you see the extension of resection from the base of tongue down to the posterior wall and to the postcricoid region. And this again, when you see this patient, this is normal life, quality of life 100%, because nobody will know that they had a big tumor. He will eat and drink.
Wie geht es Ihnen heute?
Ja, keine Beschwerden, kann nichts sagen.
He had no problems. So, of course, I show you the best cases, and not the cases with many problems, but you can believe that we have treated in the last 27 years 3,500 patients with cancer in the upper aortic digestive tract, curatively and palliatively. And now we come to the results. You see that in piriform sinus cancer, a published paper, 74% belong to the stage 3 and 4A. We had 4% bleeding, 1 edema, and 1 stenosis. Patient needed a gastrostomy tube. Recurrence in T3, 12%, in T4, 21, and local regional recurrence, so 35% recurrences. But what is important, how was the treatment of the recurrences? You see that we had only 1 total laryngectomy for salvage surgery. 6 patients had palliative treatment. They refused surgery, or the tumor was too advanced to perform surgery for salvage. And the other patient had again laser or in combination with radiotherapy. So we have a high rate of organ preservation in this material. And you see in stage 3 and 4, the recurrence-free survival 5-year Kaplan-Meier 69, and the overall survival stage 3 and 4, 47. Every second patient was still alive. You may say this is a selection effect, but when you compare with other material from the last 25 years in the world literature, you have difficulty to find the results of stage 1 and 2, the results as we have achieved in stage 3 and 4. So everyone he knows how bad is the prognosis of hypopharyngeal cancer. And the problem is how we can explain why the results are so excellent. Of course, one factor is the selection factor. These are selected patients with the aim to preserve organ, and there were no distant metastases and no second primary and no pre-treatment. Now I summarize the advantages versus standard therapy. Thanks to the specific cutting properties of the CO2 laser and the high magnification of the microscope, as well as the transoral approach and the unconventional technique of blockwise resection of larger lesions, the tumor can be removed safely by individually adapted, custom-tailored surgery with preservation of functionally important structures. Further advantages are that there is a free option for any kind of surgery. Laser surgery can be repeated at any time. It can be integrated into any therapeutic concept. There is no reconstructive surgery necessary. And by the way, we were discussing hemoglobin. None of these patients had primarily a blood transfusion. of these patients. The peri and postoperative morbidity was low, the same for the complication rates, and this is a very, I think, if you look at the results after radical surgery or after chemoradiation, you have much more problems with need for tracheotomy or, for functional reasons, total laryngectomy. The reintegration into work and social life is more complete and faster achieved, as well as improvements in the patient's psychological situation. In the last 2 decades, we could show that transoral laser microsurgical resection for organ preservation is an efficient alternative to open surgery for moderately and more advanced laryngopharyngeal tumors. The oncological results are similar, the functional results are better, and the morbidity lower. Transoral laser surgery is more effective than any organ-preserving chemoradiotherapeutic regimen. Apart from the local control and survival rates, the quality of life, which means breathing, swallowing, talking without tracheotomy, this is quality of life, is considered to be increasingly important. We as surgeons have to consider this fact to prolong a life worth living. Despite the modern possibilities of voice rehabilitation after total laryngectomy, such as voice prosthesis, the effects of a permanent tracheotomy negatively impact quality of life. The challenge for head and neck surgeons is to give patients a greatest chance for cure without loss of quality of life. At present, our favorable results demonstrate only a positive trend towards better survival after following organ-preserving surgery, but they encourage us to continue the organ function-preserving approach. Final proof of the efficiency of our therapeutic concept requires well-designed prospective studies with standardized surgical procedures carried out by head and neck surgeons skilled in laser surgery. And now I show you the last video. Is not advanced tumor, but a very interesting case. This is a 29-year-old opera singer who has, unfortunately, a hypopharyngeal cancer. And you will see, it's difficult to see on the endoscopic view here, postcricoid and piriform sinus, a superficial tumor, only 7 millimeter deep infiltrating, and lateral wall and postcricoid microcarcinoma. This is the main tumor in this 29-year. And you see during microlaryngoscopy tumor here and laterally. This is the lateral wall, medial wall. And now you see at the end of surgery, here the arytenoid, here you see the wound cavity, the thyroid cartilage, and this is after some days before he went home. You see the wound cavity with fibrin exudation. This is the healing. Definitive healing. He's over 1 year free of tumor and here in Göttingen. Here's the singer, and here you see Myers and other colleagues for the last meeting. Thank you.